Thank you. Nice to meet you all. I realised, having sat through the talks yesterday and this morning, that I'm a very different presenter to the rest of you. You all come from a clinical background, you're presenting your clinical stories. I'm a scientist, so my doctorate is in solid state physics, not people. But I have worked with medical profession for 20 years because I thought that actually what I know applies, micro, nano, all the things that we hear about. Actually, I know about that. That's my skill. And it suits humans more than it does sort of cars or missiles or things, which is where I've come from. So 20 years ago, I started this journey saying I can understand how people walk and I can do something about it. So I'm going to talk, this is sort of 20 years of summary that I'm going to go through now when I find the right button. Yeah. So we are established in the falls and frailty market. And I think that that's important because you all talk, and I have heard lots of mentions, various aspects about gait, walking and what you do. And it is fundamental to any orthopedic surgeon, you know, well, unless they've got a shoulder injury or something, but generally you are all talking about keeping people moving and well. We've sort of gravitated to the falls and frailty market because that's where nobody gets any help. It's really interesting that that when you get into this 60s, 70s, you might get a joint replacement, you might not. It's one or the other, but a lot of people are suffering whether or not they've had a joint replacement. And this is what I find quite horrifying. And in the falls and frailty market, many of those people are orthopedic patients, ex-orthopedic. So we started, we made a system, and the first place we tested it was the Royal Orthopaedic Hospital in London, where they said, well, you can't do anything until you understand what a healthy variable gait is. That was published in 2015. So since then, we have measured thousands of people. So we know what the biomechanics of a person that's healthy is. And I think in our healthy subjects, the eldest was 97. So we've covered from 18 to 97. So we actually made a very focused attempt to make sure that we get the 50-year-olds, the 60-year-olds. Because so many people say, oh, that happens. Well, what happens? So that, and we proved quite clearly that you can be old and walk away, you know. So that is a fictitious, incorrect statement that we keep brandishing around everywhere. We have got a lot of evidence, and I'll go through what our intervention program is, how we do it, what it means. But we do know why people fall, what you can do to help them not fall, and what that means to them in their future life. And we go through various programs, but we always find that people, there's always going to be some that don't respond, but the number that do is startling high. You know, we typically, in any study, formal study, informal, it's about 90% of the people that we can, once you understand the problem and you tell them the problem, they are receptive to do something. And our goal was always make it accessible to everyone. So it had to be low cost. So I've spent 20 years on this. The first system wasn't low cost, it wasn't easy to use. The second generation is low cost, easy to use, and it's designed like that so anybody can be measured anywhere. And obviously we can prove all sorts of savings, but I can guarantee however you do your sums, you will save money. So let's bring this back to your world, the osteoarthritis world. You diagnose them. Normally in the UK, the nice guidance is now, it is only on, can you sleep at night? Can you walk? How bad's the pain? That is the diagnosis. A lot of other countries have different forms. Some do them, you know, we don't recommend an X-ray now because it doesn't tell you much until it's so late that you know you've got to replace it because it's showing bone on bone. So we have the diagnosis. We then get treatment, and in the UK we'll say, right, you need to go to an exercise class, you need to go to an MSK class, you're going to go and do lots of exercises. A lot of people don't do that. A lot of people aren't very effective at doing that. And that's why we end up with this long list. And certainly in the UK, it's a very long list. We don't prioritise our list. It's the first come, first served. You're on the list. You wait as long as the list is. And some of our recent data shows that's probably not the right thing to be doing. Again, I'm giving UK numbers, but we all know around the world, these numbers are big. The number of joint replacements is probably about 3 to 5% of people with osteoarthritis. So a lot of people do live with osteoarthritis, but those that go on for joint replacement are typically 250,000 in the UK every year. Then we get this post-op, and I know there's quite a few orthopaedic consultants, surgeons here. You measure, you do your patient, you do your job, you probably do a very good job. Most surgery is probably very effective. You may see the person if they have an infection. Occasionally it comes loose and you have to do a revision, but generally you just, yeah, you're fine, yeah, you're walking, off you pop. So you get this sign off, and then there's this muddy area. Well, are you happy? Are you doing what you should be? Are you happy with what you're doing? Good old Oxford hip and knee score, it always focuses on the one joint. Is that joint pain gone? Can you now do things? It's a very subjective outcome, which this country relies on. But even then, if you look at it, 25% of knee patients aren't happy, 10% of hip patients. But that doesn't tell the whole story. And I have been telling so many people because it's quite frustrating. Because 1 year post-op, then the majority of them, or at least half of them, aren't right. They're not walking properly. What does that mean? Well, it probably means they're on another list for another joint replacement, or they were having got arthritis in another joint, or they're in the falls clinic. So these people carry on going through the system, but they're not back with that surgeon because not many of them actually need that one revised. So I actually just looked at these numbers. These are 10 years ago. We published. So one of them was done at Exeter, one of them was done at the Royal Orthopaedic Hospital. And it's quite clear at 6-8 weeks, there aren't many people that are very good at walking. They might be walking, but they're not walking well. I don't know how many of you are used to looking at kinematic diagrams. I'm sure some of you. But basically, and I'm going to walk across the room so we won't be chatting, but we walk, we have a hip angle, we should be symmetrical. I think we have the Beatles walking across. We're meant to be symmetrical front behind, that's right. And then we're meant to kick that foot back, pick it up, bend the knee, put it down. When we put it down, we bend it to take the impact as we load, and then we start. That is all we do. So the knee angle goes from straight, slight flexures when it's loaded, straight again, and then up in the air for the swing phase. The hip, I call it an upside down W, but basically it's behind and in front. And it should be the same amount behind and in front, or as close as possible. You should not be moving the pelvis. You should move from the hip joint. and you should move in that plane, not any other plane. Now, the problem is, I mean, I've been bashing around this for, like I say, a long time. The reason is most people try to visualize this, and it's impossible. It is absolutely impossible to visually see that with your eyes, because that cycle is about a second. The eye refreshes every 25 hertz. So you get 25 images of all of that. Doesn't stand a cat and mouse chance. You don't, it just won't happen. So nobody actually knows what the knee bend is, should be, what the hip bend should be, and you certainly don't see the knee flexion on load, because that is almost impossible to see. So what most people watch is the upper body reaction to a lower body problem. So if you move from the waist rather than the hip, so we've got the hip problem, I can either move from the waist and do that, or I can swing it round. I only have two ways of getting it from here to here. For the knee, I can't bend it, catch the floor, forward. So gait kinematics do cause falls. They cause all sorts of other things. That's one of the things they do. So if you don't put it right, you haven't got your balance and you haven't got the clearance to get that foot from A to B. Right? So it's very, very simple. You need to get that movement back. And if you don't, you're loading the other joints incorrectly, so they become arthritic, or you fall over. It's a very simple story. This is something you'll have never seen before, but it's my lovely graph. You are used to graphs, most people. I present this at retirement villages, and you'd be surprised how much they will understand. But this one, there's 1,423 people on that graph. These are just people that we've measured or have been measured with our system. So what you will understand, and everybody understands, is the vertical axis, gait speed, right? We all understand that if somebody walks at 1 meter a second or more, we class them as healthy. You're okay, off your pop. You're not going to cause me any problems. A slightly slow walking speed, 0.8 to 1, that is where they say cognitive decline, because your brain's not, if things aren't pumping round as they should. But then we go down into worse problems. We get the problems that you can't do all the normal activities of daily living. And then you get the problem that you might be able to have a little fall, or, you know, the arthritic community is sitting in this area. But then you go down, and the people sitting between 0.4 and 0.6, they may have had a joint replacement, they may have had 2, they may have had 3. They're not very well, and they are probably heading into functional institutionalization. They're certainly in functional decline, and then you've got the bottom lot that are probably in care, using a walker, trundling around. Those people we don't want. We actually, this simple graph has separated it. So out of 1,400, we got 400 that we class as healthy. We got 70 people that are probably in care homes or heading there. We got 167 that could be there any time. We got 150 that are very likely to be falling over. So we can see, we can tell the story, and this is of people. The other thing you can see is there's a very strong correlation between total joint angle and gait speed, which means if I measure somebody's total joint angle and it's not right, I can absolutely guarantee they won't be walking properly, they won't be healthy, and I can almost put them in a bracket. And that's really important, because I'm addressing the problem, not the end outcome. So gait speed is used as an outcome, but you can't tell somebody to walk faster because they'll fall over. They're walking slower because there's a problem. You need to address the problem. Kinematics is where the problem lies. You need to address that, and then magic happens and you move and you get them walking properly. And also note, there is only a moderate correlation between age and total joint angle. So it's not strong. And this is people that we've measured that probably, you know, need help. So I won't go into details. Well, we'll actually show a bit more about the intervention. But this person, actually 6 months post-op, they've been signed off, they live in the community, they're just getting on with life, not very well. So they're walking at 0.8 meters per second, and they've got a total joint angle of 158. Typically, we say 200. So if you've got all the joints moving as possible, 200 is a good number. 158 is not, and you can see it's clearly the right knee. They haven't got over the right knee replacement, and they've got sort of early stage sarcopenia, weakness, whatever you care to call it, in all the lower limbs. But we know that, and they know that, and I'll explain how the intervention works. But after giving them 4 sessions of biomechanical input of these are the exercises for you, not we've got a bag for hip replacement, knee replacement. These are your exercises, and we're going to monitor you through. So which works, which is the driver? Both of them. They know the problem, you know the problem. And after, this is a 4-session program over, so it's 12 weeks, 4 sessions, rinse and repeat. You've now got that person, not quite perfect, but pretty damn close. So total joint angle is not quite 200, walking speed is over 1 meter a second, and they are now, you'd be class them as all right to get on in society. So why do we do this? What are we trying to do? We're trying to get this information to the person, because with the best will in the world, people, once they've got data, they can act on it. We always have our blood pressure taken, we have a bag coding for that, we have our lung capacity bag coding, we have all these measurements, everything is a number. Our cholesterol levels, whatever we go, we get a number, we get told what it is, we tell how bad it is, we're told what to do, and then we go home and do it. We don't do that with kinematics. We don't do that with walking. We say, oh yeah, you're a bit wobbly, right, and then we'll send them off here or there, different physios. Many times we find that the physio will focus on the joint that's been done, not realising that the whole body's gone skewy. So we find that people are just left in this limbo. And as soon as you tell them, this is your problem, this is what you can do about it, off you go and do it, they're fine. 90% of the people get better. That's a pretty good, and compared to, and this is objectively, not questionnaires, this is like, I know they're better. You could all use it in problems. I'd love to see in surgery a proper number coming out saying, I've done the job, I've done what I should have done. And the cost, like I say, it's low cost. So this is the kit. I normally take it round, and I suddenly thought, oh, I haven't brought it with me. It's a little bag. And I measure people, walking up and down out here. It really is simple. The sensors go in the straps, over clothes, because you do not want to be undressing old people or anybody. You know, it's this, straps on, walk 10 strides, turn around, come back, straps off, done. The whole thing takes 10 minutes and it's done anywhere. So this is how the data flows. So it's designed for an assistant, because again, we know there aren't enough physios. We know people don't get to see a physio. We know there's so many times when they don't have any input. So it's designed to be used by an assistant somewhere, anywhere. They go over clothes, they go on the pelvis, thigh and calf, and the base of the spine. That data is uploaded to the tablet, Bluetooth, and then internet to the cloud. all the data is analysed in the cloud. So it doesn't matter who measures someone. It's taken out the need for the expert, and it's done it. So I could do a measurement, a colleague could do it, anybody could do the measurement, and it will be right. It does the same processing. So I don't have many clever slides, but I do have this. If I could find how to move my little cursor. How do you move the cursor on this? Oh, no, not like that. So that is the person walking, right? That is our data fed into a musculoskeletal model. So we generate the person walking. From that, we can tell which muscles are weak, which muscles are normal, and which ones are strong. But the important thing is then we can work out which are weak, which need strengthening. And then I can find it cursor again. So this is one of the exercises we model. They're all load bearing because walking is load bearing. So the whole point is you want to get exercises that are effectively part of their gait cycle. So all of these, they're all standard NHS, Targo-E type, strength and balance, do it at home, safe as houses. Because obviously most of the people we deal with have got an average age 70s, 80s. They're not youngsters. If you give them, like, lie on the floor and put this elastic band here, they might never get up and you've suddenly caused them a disaster. So we would never ever do that. So we have done a lot of trials, observational studies, a lot. And then we said, okay, so can we do an intervention? Can we follow that process and intervene and do it scientifically from one end to the other? So this was actually during COVID, which is quite interesting because obviously there were still a few people getting joint replacements. We didn't get too many, but we got 22 in each group. So they are the same, same balance of hip and knee. So again, I'm going to dispel this theory that hip recovery doesn't need rehab, knees do. That isn't true. We have so many hip patients that we could disprove that. Average age, 70s, gender, doesn't really matter, but it's 50-50. Average number of joints they've got, you see, on average, they've already got at least 1.5. So we're not doing a good job unless I do appreciate that some people it's genetic. A lot of them it's just, it'll be this one and that one because that one is the one that's suffering because of the incorrect loading. Guess what? That's, they've come in. And they've got, on average, half fitted joints. So these are poorly people. They're not single, they're not just a single replacement patient. Now, I know there's a lot of lines there, but I thought it was interesting because if we start with somebody with a joint angle of 120 degrees, they've got a long way to go to get better. However brilliant your surgery, however brilliant your rehab, they've got a lot of work because those muscles have got so weak, they're doing everything wrong and they've got to build that up. Otherwise, they're always going to be in that area where you say, I'm going to have to do something with you. So with all these people, these are lines. You can see the 200 degrees is where I'd like to say that's where you should get to. The standard of care, so the blue, the top one is the start and the end of 12 weeks intervention. And you can see a little bit of Some have done quite well, some have gone backwards, and that's not very good. You know, I've had my operation, now we're going backwards. But generally, it's a few degrees. And on average, from hip and knee, you can see separately, but at 6 weeks, they're around 170 on average. So they're 30 degrees lower than we'd like to get them to. And for the 18 weeks, the standard of care hasn't moved up hardly at all on average. So some people got better, some people got worse. So on average, we've done that all, right? We haven't really helped them walking any better. The intervention group, we went up 10 degrees on average. Now that means some got better. I think there was 1 or 2 people didn't, but that was a much better 90% improved. And that was a proper improvement, almost the p-value, considering we only had 22 in each group. That's not bad. So you can see what we're aiming to is get them across that way, get everybody to that line we've done. So at 10 weeks, if you looked at those graphs, 10% had a good gait. So 90% needed intervention if we want them walking properly. With the AI intervention, we got only 9% failed to respond as opposed to 36% in standard care. And it does have a direct impact on their health. It's not just, oh, it doesn't matter if you're a bit this. It will affect them for the rest of their life. We all have this, well, we'll do a bit of rehab. We got 6 weeks in this country. Off you go, you get 6 weeks, right, that's it, you're done. Right, okay, well, where am I? Did I need 2 or did I need 20? You know, and it's just, we stop because the money's run out. We've given you that, that's it. And the other thing we've proven on this and many, many others is it doesn't matter if they're a year post-op. You can still intervene because it's not the joint, it's the muscles that need strengthening, and muscles can be strengthened at any time. So then we started looking at whether you could get them ready for surgery better. And if you could, does that actually give you any better answers? We're partway through this, so I thought I'd give you some early data from it, but it's got ethics approval. We do it at the same hospital that we did the post-op, so we've got continuity of there. We've only got 8 people finish the full protocol, and that protocol is start them 12 weeks pre-op and then take them to 12 weeks post-op, but not give them the post-op rehab, only the pre-op rehab. So Gait Smart is used at the beginning and they get the 12 weeks, 6 weeks, and then that's meant to help them. In reality, in the good old UK, we find that our 12 weeks can turn into 40 weeks quite easily. So these people are really struggling. And that's why I say you can see the problems we have, certainly in our UK data. In the Gait Smart group, there are only 4 in both. One of them didn't improve, so we've got a problem there. But generally, they have improved by 10 degrees. So we're getting this nice 10 degrees. So give them 4, 10 degrees. And this is what I look at all the time on all our intervention protocols. I say, that's my goal, improve their joint angles by 10 degrees, get them up by 0.1 of a metre per second, which is clinically significant, and get them moving better. That is sort of embedded into my mindset. But this is, we've got more in the middle. So I thought I'd take the pre-op to 6 weeks post. And we're also doing some in private healthcare. And what you can see immediately is private patients are done earlier. So their average start point pre-op is 174. as opposed to in the NHS, it's 159. So I've lost 15 degrees, which is all the rehab programme. That's a lot of movement, and I've lost it. And also, I'm not in a lot of pain, so probably I can recover quicker once you take that pain away. And you can see sort of early stages, the private patients are doing better because they're done earlier and they stand more chance. Some of them have just changed. It's transformational if you look at the data. Whereas ours, we do have some, but not many. And it isn't just hip patients do well, but knee patients don't. This is not the case. There are some that do well and some that don't. And it's because there is a whole body behind. So the surgery might be easier for hip replacement than knee, but it's not just the surgery. In fact, it's mostly not. Take the pain away, those muscles are weak, and you've learned how to walk differently. So we've got hundreds, thousands of people. And we do also, most of our data now, other than the formal trials, comes from the community. So we work with Age UK in this country, we work with community active groups, we work in primary care, we are just going into a residential retirement village. So we are all over the place because that is where the pull is. And every time I go somewhere, I say to somebody, when did you have those knees replaced? They say 3 years ago. And I say, you're not using them. You've still got a joint angle as if you went into surgery, 40 degrees. You don't tell them they're going to fall over, but they will trip. 40 degrees isn't going to give them foot clearance. They then have to use walking aids and this and that. And a lot of them are in sort of residential care, and it's such a shame. You see them, they've lost, they're fearful because they probably are going to fall over, so they're terrified of doing things. It's just a nightmare. So I would strongly urge anybody that's looking after patients to don't just dismiss them and say, well, I've done my job, you're all right, no infections, nothing to worry about, it hasn't had to be redone, off your pop, because there's a person behind there that isn't doing very well as a result. And I just remind you of this knee patient, 6 months left, and we really don't want those people. Didn't take much, and there they are. So it's not impossible, and we can do it. So what would I say? I would urge everyone to measure gait kinematics because it tells you a whole story. Walking speed tells you they're slow. It doesn't tell you a story. Gait kinematics tells you the whole story. You also, none of you, I've searched and searched and searched. Nobody does healthcare costs of these people because they're not their people anymore. They're someone else's person. Falls clinics, you can't get to them. Go to hospitals and they say nobody's looking after these people when they've had a trip. We just, well, that happens. We don't cost it, so it doesn't matter that we don't do it. As soon as you put a cost on that, and I would estimate that each of these people we save about £2,000 just by putting through that little programme. £2,000 on the healthcare costs every year. And you keep them at home. So it really is important. The AI does work. I mean, obviously there's other ways. If you want to do a completely different intervention, that's fine, but use the data to drive that intervention and use the data to prove that your intervention worked. Because if you don't, you're relying on, I mean, proms have been out forever. You don't go and have your heart done and it says, how do you feel? They bloody well measure you. You know, it's just like, how do you feel, Mrs. So-and-so? Oh, I'm fine. You're using a walker. Ah, it's all right. I'm happy. No, you're not very happy, but you think that's the best you can have. It's not. So, any questions?